Good day. My name is Imelda Williams. This presentation will focus on the normal radiographic appearances of the chest X-ray. It's important that you apply a systematic approach when you view chest images, as the chest is quite difficult to interpret. If you apply the systematic approach, it will help you to avoid pitfalls. I've given a number of resources, and Bontrager and Lampignano is the textbook for radiographic positioning, and Chapter 2 refers to the positioning of both the PA, AP, and lateral views of the chest. In the Advanced Image Interpretation Manual, the pages are from 70 to 87. And then in the book by Otto Chan, the chapters is Chapter 12. Chapter 16 refers to the pediatric chest. And then in Clarkson Ducks, which is Chest X-rays for medical students, Part 2, is related to the ABCDE of chest X-rays. And then in the textbook by Raby on Accident and Emergency Radiology, Chapter 18 is the one to read. So all of these resources are electronic, and you will have access to that in the Moodle book. I hope at the end of this lecture you should be able to identify the normal radiographic appearances on both the adult as well as the pediatric chest X-ray projections. And it's important that you develop a systematic approach to interpret plain radiographs of the chest, because these are never easy. And I've given you the chest X-ray projections and with the labels included. So important on the PA chest is to check that the airfold trachea is central, and also look at the medial ends of the clavicles. They should be equidistant from the spinous processes. Important to look at the carina, and then also our ribs. So you want to identify what is anterior ribs and posterior ribs, and then ensure that the right costophrenic angles are on the images, and you should be able to see through the mediastinal region. So to be able to count the posterior ribs on a normal radiograph with good inspiration, you should have about 10 to 11 posterior ribs on that you can see above the diaphragm. So to distinguish between the posterior and the anterior ribs, remember the posterior ribs goes right up to the vertebra. So they normally go towards the middle of the spine, and to the middle of our image. And then the anterior ribs curves down, and then they stop bluntly because they have cartilage that attaches them to the sternum. So on the lateral view, you should be able to see the lung apices quite well if the patient's arms have been moved away from that space, and the body of the sternum as well as the thoracic vertebra should be in true lateral positions. And then you should be able to also have the posterior costophrenic angles all onto the image. Wilson highlighted 5 major points to consider, so that if you consider these steps in conjunction with a systematic review system, that would help you to avoid pitfalls. And the 5 major points are documentary information, technical considerations, detection and description of abnormalities, generic diagnosis are probably sufficient for a course like this, and then specific diagnosis. So with documentary information, according to the justification rules for a referral, there must be some clinical reason for performing the examination, and this must be satisfied. So always check the following: the name and age of the patient, the date of the examination, and then check against the request or the referral card and the clinical details, as these may have a bearing on the diagnosis as well, being legal means for correct identification. It's important to check whether the patient has had previous x-rays done, so look at previous notes or previous history, as this can relate to current changes that you see on the chest x-ray. Check whether the patient is a long-time smoker, so look for signs of COPD. If it's work-related, for example, if they've worked with asbestos, you would see calcified plaques on the chest, and then a history of tuberculosis, so look for signs of old fibrosis or calcification. And then also be aware of recognized congenital abnormalities. So, for example, dextrocardia, where only the apex of the heart is rotated to the right, or situs inversus, where there is reversal of the major visceral organs. So the technical considerations then, there must be a side marker. If the projection is PA, this will generate less magnification of the heart. An erect form allows evaluation of air fluid levels, the relative size of the upper and lower zone blood vessels, distribution of air and fluid in the pleural space, and assessment of position and contours of the heart, mediastinum and diaphragm. And that is why a erect form is preferred rather than a supine chest X-ray. The inspiratory effort is important. A shallow inspiration can result in pathology, the simulation of pathology. The midpoint of the right hemidiaphragm lies between the 5th and 7th anterior ribs and is likely to reflect an abnormality. With underinflation, this makes this differentiation between the upper and lower zone vessels virtually impossible, and the contour and size of the mediastinal contents are also radically affected. So when we talk about penetration here, we refer to the KV techniques that's been used, as it affects the ability to see elements of the mediastinum. Rotation in the chest can take place in 3 axes. So in the long axis, this causes inequality of radiodensity of the hemothoraces, so one side will be a little bit whiter than the other. It also distorts the mediastinal structures. And this is assessed by reviewing the relative positions of the clavicle ends. So the medial ends should be equidistant from the spinous process of the thoracic vertebra. Horizontal coronal rotation creates kyphotic or lordotic projections. Lordosis will project the subclavian vessels and main pulmonary arteries into prominence. And this is assessed by relating the position of the medial end of the clavicle relative to the normal overlap position of the posterior end of the 4th rib. Horizontal sagittal rotation is the result in chest tilting. Where there is no rotation and the patient is straight, the film can reveal a depressed sternum or kyphoscoliosis, and this is shown by the distortion of chest content appearances. So in terms of image quality, first check whether the projection was done in a PA or an AP position, or whether it was done as an erect or a supine position. The orientation then is to check that the correct markers are on. And for penetration, so referring to our KV, the penetration should be able to see the lower dorsal vertebra through the heart. So if you want to check for rotation again, so medial ends of the clavicle should be equidistant from the spinous processes. If there's rotation, it alters the size of the hilum, and it can create false changes in the radiodensity of lung fields as well as the cardiac silhouette. The degree of inspiration, so as mentioned, with poor inspiration, this causes the heart to be pushed up and widened, so it creates a false cardiothoracic ratio. It also creates crowding of the lower zone pulmonary vasculature. So to detect and describe abnormalities, the system that I suggest is to review the various parts of the chest film and to adopt a 1, 2, 3 review system. So for line 1, look for the name, date and marker, and consider the apical segments of the chest. Line 2, check down the middle to see whether there's any signs of rotation and whether the lung fields are even in density and size. Is the trachea central? Is the chest correctly exposed? You should see at least for thoracic vertebra through the trachea. And then with line 3, you should assess the lung bases. So you want to check whether adequate inspiration has taken place. You want to see where there's at least 9 or 10 posterior ribs visible. You also want to look underneath the diaphragm to see if there's any signs of abnormal air. So this is what it should look like on the chest x-ray. So line 1 then is the horizontal line, and to check the patient ID, the date, the markers, as well as the apices. Line 2 is the line that runs down the middle, so you want to check for rotation, lung size, density evenly distributed across both lungs, that the trachea is central. And then line 3 is check for the lung bases and also check for adequate inspiration. Now reviewing the diaphragm, heart and mediastinum. So follow the dotted line around to assess the diaphragm, the heart and the mediastinum so that you can search for evidence of free air, particularly on the right hemidiaphragm or under the pericardium. You want to check the heart size and what is the shape and that of the aortic knuckle, and also you want to look at the hilar vessels. So looking at the mediastinum, the right side of the mediastinum and the right border is formed by the right innominate vein and the superior vena cava. There is ectasia or unfolding of the innominate artery or aorta, and these structures may form the border. In about 65% of subjects, a stripe of up to 3 mm thickness is generated in the right paratracheal region, and that is by the lung contacting the tracheal wall between the clavicle and the azygos vein. Visualization of the stripe through the innominate vein and superior vena cava allows space-occupying masses to be ruled out. Air in the lung will often outline the azygos vein at the lower end of the stripe. The vein in the normal person should be under 10 mm in diameter. The retrotracheal lung space will interface with the right esophageal wall, and this will generate the esophageal pleural stripe if air is present within the esophagus. This is revealed as an upward and outward curving line seen behind the trachea. So to remember that there are potentially 3 interfaces which you can see on the frontal view or the PA view in the right superior mediastinum: the superior vena cava border, the right tracheal wall, and the right esophageal wall. Now looking at the left side of the mediastinum, the low density to the left of trachea is created by the left carotid and subclavian arteries, as well as the left jugular and innominate veins. There's usually a gentle curve created by the left subclavian artery that fades on entry to the root of the neck. The outer margin of the left tracheal wall is never visible, as the lung is separated from the trachea by the aorta and other veins or arteries. When a radiologist reports, they would quite often report on zones. So when they refer to the upper zone, that is the area which is from the second anterior rib and above. The middle zone refers to the second to fourth ribs anteriorly, and the lower zone refers to the fourth anterior rib and below. On the lateral view, the superior mediastinum is at the level of T4 and above to the manubrium. The anterior mediastinum is the part in front of the heart. The posterior mediastinum is posterior to the heart, and the middle mediastinum is the area that has the cardiac outline as well as the great vessels. The mediastinum on the lateral projection. So with the trachea and retrotrachea, airflow through the trachea will descend downwards obliquely and posteriorly. If there's aortic unfolding, this can cause forwards bowing, but there are normally no indentations from other structures. The carina is invisible on the lateral view. It is also rare to see the anterior tracheal wall. However, if visible, it is normally 2 to 3 millimeter thick. Esophageal wall may cause thickening. A 1 centimeter band may separate the collapsed esophagus from the trachea as the posterior tracheal stripe. So looking at the sternum to the ascending aorta, this should be of similar density to the area behind the left ventricle. Large fat deposits in the retrosternal space may make differentiation from other mediastinal masses very difficult. The supra-aortic mediastinum, you could have a degree of aortic unfolding, and this controls the extent to which the aortic arch and great vessels are visible. The innominate artery is most frequently seen vessel and is noted as a gentle S-shaped interface crossing the trachea. The innominate vein may be seen as an S shape. The vein conformation is assured where the outline is noted to continue below the aortic arch to the superior vena cava. The right middle mediastinum under the azygos vein. Behind the heart, the lung is in contact with the esophagus until the azygos vein arches forward and right to enter the superior vena cava, and this then generates a new interface. This line should be straight in the upper part or concave toward the lung. Convexity towards the lung would suggest a subcarinal mass. Remember, this may be the creation of a bulge by the azygos arc at the mediastinal lung interface at the carina. So do not misconstrue as adenopathy or other pathology. And just a few thoughts on paraspinal lines. The fat adjacent to the left and right margins of the lateral spinal ligaments creates the paraspinal lines. Lymph nodes and intercostal vessels are usually invisible as individual structures. The left paravertebral space is larger than the right side and can be up to 1 centimeter. Aortic unfolding adds to the left paravertebral line thickness. The retrosternal line is an opacity on the lower half or third of the anterior chest wall. Variation in anterior extent of the lungs can cause differences in its length as well as thickness, and this may simulate pleural or extrapleural disease. I'm still sticking to the mediastinum on the lateral projection. So the left cardiac border under the aortic arch. This border is formed from the main pulmonary artery and heart with smoothing of the angle, and this is created by the mid portion of the main and left pulmonary arteries by the pleura. The aortopulmonary stripe is an important area to assess for lymphadenopathy as it marks the extent of the aortopulmonary window. The left superior intercostal vein arcs forward around the aorta to enter the innominate vein. This may create a small nipple-like projection on the aortic knuckle, and this must not be confused as adenopathy. The left lung interface with the aorta can be seen to the diaphragm with an interruption by a silhouette of the left proximal pulmonary artery as the interfaces passes behind the left bronchus and the heart. The inferior vena cava is seen in approximately 95% of subjects as it enters the right atrium. Sometimes the straight border connecting the IVC and the SVC can be seen. And then the scapula. Thin cortical lines may be confused as pleural fissures when seen as linear lines emanating from the lungs. Scapular angles may be mistaken for masses on the lateral projection, with axillary skin folds being especially problematic if it is projected over the anterior mediastinum. Now moving on to lung edges. So you need to look for the lung edges and associated with pneumothoraces, so you want to see if there's any evidence of effusion, and this will be seen as blunting of the costo and cardiophrenic angles. Haziness of these angles may also be generated by overinflation. So in the pleura then, you want to see if there's any evidence of thickening or tagging of the pleura. It's also important to look behind the heart because that could show any potential diaphragmatic hernias. So with the posterior ribs, you need to compare both sides. So look at the lung fields from side to side and check whether all the ribs are present or whether there's any changes in densities in either the ribs or the lung, because the ribs are common for metastatic deposits. Where abnormal shadows are detected, class them as either black or lucent or white or dense, lung or rib, and consider whether further management needs to be included. The anterior ribs, examine the skeletal components from side to side. Note also abnormalities such as fractures, shape or density changes. Remember, previous fractures may display callus from many years ago. I'm moving up to the neck and the soft tissues. So begin the examination at the root of the neck and note any bony cervical abnormalities. Continue by following a line around the soft tissue through the axillary region, over the breast shadows, and back around the opposite side. You need to assess for any evidence of a mastectomy, so if you have a female patient, or any breast enhancement or thoracotomies, and also look for abnormal air in the soft tissue that could represent a surgical emphysema. So what next? Once a screening procedure outlined has been followed, this will allow a rapid evaluation of the chest radiograph to see whether there's any evidence of abnormalities on the image. Most examinations are normal, and that you need to remember, or might display no significant appearance, for example, calcifications or anatomical differences. However, if an image shows that there is significant or abnormal appearances, the concept of shadow should be introduced. These are, if it is too black, then you should think about a pneumothorax. If it is too white, then you should probably think of something like an effusion. If there is soft tissue density, that would equate to maybe a collapse or shadows. It's important to also look at the position of the trachea, as it is useful, as it acts like a pendulum to move as a result in changes in lung volume. So let's just quickly go through the ABC search strategy. So in terms of adequacy, in terms of having the radiographic anatomy on, the PA view should have from the apices to the costophrenic angles. The lateral view also the same. On the PA view, the scapula must be projected off the lung fields. And then just again about the alignment. So to check for alignment, look at the clavicles on the medial ends, whether it's equidistant from the spinous processes, and they must not be obscured by the apices. The central mediastinum and the heart should be defined sharply. The airways, the trachea should be central above the manubrium. Also look at the angle of the carina. This can vary from 40 to 100 angle degree. If it's greater than 100, then you should suspect some pathology, for example, adenopathy. And then exclude any possibilities of foreign bodies, especially when you look at the chest of a pediatric patient. And then still with A, so if look at all the lines. So for example, if the patient has an endotracheal tube, it should be at least 3.5 to 5.5 centimeters above the carina, and this you can see on the chest of the pediatric patient. And then the central venous catheter must be at the junction of the superior vena cava and the right atrium. The nasogastric tube must pass below the diaphragm and into the stomach, and we can see on the chest at the bottom that the nasogastric tube has actually gone into the right lung, so it's not in the stomach, and it appears as if they've started feeding this patient, because you can see that there is some white density, so there's consolidation around the misplaced nasogastric tube. Now moving on to B, which is the breathing. So check your ribs to ensure that the lung is fully inflated. So you should see at least 10 posterior ribs or 6 anterior ribs above the diaphragm, and look at the demarcation of the lung tissue from the hilum to the periphery. Check the edges of each lung and make sure that you look at the costophrenic angles, that it is nice and sharp and acute. And then moving on to C, which is our circulation. So this is the mediastinal area. Check the cardiothoracic ratio. The mediastinum position should be 1/3 towards the right and 2/3 towards the left. And then for the hilar, evaluate the size, the shape, and the position, and then ensure that you look for any abnormal shadows behind the heart to exclude hiatus hernia. And I'm sure you know how to measure the cardiothoracic ratio. So that should be less than 50%. If it's greater than 50%, it gives an idea of cardiomegaly. And this is best measured on a PA erect view, so that there is no magnification of the heart. The hilar, the right side is mostly a little bit lower than the left side. It contains the hilar lymph nodes, so if there's hilar enlargement, then you should suspect, for example, that there's either a mass or adenopathy. Now moving on to D. So the first D is disability, so you want to see if there's any abnormalities such as fractures or rib abnormalities. If there's fractures of the ribs, then try and see whether there's maybe a pneumothorax due to the fracture, and if there's any other rib abnormalities, is that due to metastases. And the second D is the diaphragm. So look at the diaphragms, they should be sharply outlined. The right side normally lies above the left side because of the liver, but it should not be greater than 2.5 centimeters when compared to the left. In the edges, so you want to look at the pleura. The costophrenic angle should be nice and acute. Normally you don't see the pleura, you will only see that if there is abnormal air or fluid within the pleura. And then whatever bony structures are visible, so look at any evidence of fractures if the patient has been in an accident, and then other types of lesions such as appearances of metastatic disease. And then for soft tissue, check for abnormal air. So you want to check within the neck space, look for foreign bodies in the soft tissue, and then also look at the breast shadows if you have a female patient, to ensure that both breasts are visible. If not, then you know that the patient must have had a mastectomy, and therefore look for signs of metastases. And then finally, the chest has got a lot of stuff in it, so ensure that you do the satisfaction of search so that you don't miss out on any important pathology. So just a little bit more about the neck. The trachea should be straight with a very sharp carina, and then look for symmetry, any loss of tissue planes, subcutaneous air, and breast shadows. So in the pediatric patient, the cardiothoracic ratio can be less or equal to 60%. You can measure the heart size on an AP view. And then remember, with our pediatric patients, the thymus can produce a very classic sail sign appearance. You can see this on the image, that there is a triangular density to the right of the mediastinum. With our more older pediatric patients, these patients can be positioned so that you can have a PA position as well as a lateral position. So for the pleural fissures, fissures are really complete, and therefore they can create localized defects. It is unusual to see the whole of oblique fissures. Pleuras are not normally seen, so when you see the pleura, search for signs of thickening, calcification, fluid, or abnormal air, and then check for the location of fissures and whether there's any abnormal depression or elevation. The horizontal fissure, which is visible on a PA chest X-ray, runs from the right hilum to the 6th rib, and oblique fissures are only visible on the lateral chest X-ray. Just a little bit about accessory fissures. The azygous lobe fissure is the commonest normal variation, and this occurs due to failure of the azygous vein to occupy its normal position at the tracheobronchial angle. The left minor fissure is comparable with the right horizontal fissure. It separates the lingular segment from the remaining upper lobe. The superior accessory fissure separates the basal and apical segments in either lobes, and the inferior accessory fissure separates the medial and anterior basal segments of the right lower lobe. Now, just a side-to-side comparison. The right main bronchus is more vertical than the left. The right upper lobe bronchus arises higher than the left. On the lateral film, the right upper lobe is seen higher end than the left upper lobe, and the inferior pulmonary ligaments may create diaphragmatic peaking. The right pulmonary artery and superior pulmonary vein may superimpose to create a rounded hilar mass that can be confused on the lateral. Pre-segmental lower lobe arteries are 9 to 16 millimeter in diameter on the frontal view. On the normal lateral view, the posterior wall of the right main bronchus and divisions are outlined by a thin air stripe. On the left vessels, it will intervene the left main bronchus to make the regions difficult to differentiate. Therefore, take care when assessing for hilar masses. And mass impressions may be created by visualizing vessels end-on in any projection under the left main bronchus. Pulmonary blood vessels. Visible lung markings are caused by branching of blood vessels across. Differentiation between arteries and veins in the outer parts of the lungs is virtually impossible. However, a few things to remember. The lower lobe veins pass horizontally. The lower lobe arteries run vertically. The upper lobe vessels show a gentle curving vertical orientation. The upper lobe veins are lateral to the arteries, and the upper lobe veins may be traced by the venous trunk and superior pulmonary vein. Pulmonary vessel diameter varies according to hemodynamic factors. In the erect patient, the vessel diameter increases from the apex to the base. In the supine patient, the overall averaging out of vessel size is across the lung. Although trying to identify regional blood flow, this measuring individual vessels has very dubious value, especially when you try to differentiate between arteries and veins. However, remember, the artery diameter should not be greater than 1.5 times the bronchus, otherwise upper lobe dilatation could be inferred. Vessels in the first anterior rib space should be less than 3 millimeter. And finally, on lymph vessels drain the lungs and pleura to the hilar lymph nodes, and the lymph nodes are usually invisible unless the lungs become edematous or lymphatic channels are occluded by tumors. These enlarged septal lymphatics are termed curly A lines. So the take-home principles are: you should be able to identify the normal radiographic appearances on both the PA and the lateral chest projections. You should also be able to identify what is normal to enable to identify common pathologies. For example, how do you identify a mediastinal shift? So it's really important that you apply a systematic approach when you view chest X-ray images so that pitfalls can be avoided. Thank you.